Today we're going to talk about assessment and management of patients with hypertension. Hypertension is the most common chronic disease in the United States and globally, posing a major risk for premature death, disability, and diseases like cardiovascular disease, stroke, and chronic kidney disease. The risk of these conditions increases significantly with higher blood pressure, doubling with every 20 millimeters per mercury rise in systolic or 10 millimeters per mercury rise in diastolic pressure. However, many patients can lower their blood pressure and reduce these risks through lifestyle changes such as diet, exercise, medication adherence, and smoking cessation. This chapter is going to explore the definition of hypertension, its management, and the nurse's role in assessment, education, and intervention. So what is blood pressure? Blood pressure results from cardiac output and peripheral resistance. Cardiac output is determined by the heart rate and stroke volume, while peripheral resistance depends on blood vessel constriction. Normally, blood pressure will rise and fall throughout the day, and an adequate blood pressure is needed to perfuse and oxygenate our vital organs and tissues. Hypertension can develop due to increased cardiac output, often from expanded vascular volume, increased peripheral resistance, or both. While the exact cause of hypertension is usually unknown, hypertension is a multifactorial condition with various contributing factors. For hypertension to occur, there must be changes in cardiac output or peripheral resistance, along with a malfunction in the body's pressure regulation systems. The definition of hypertension has changed over time. Previously, it was diagnosed at a systolic blood pressure of 140 millimeters per mercury or higher, and a diastolic pressure of 90 or higher, based on the JNC7 and JNC8 guidelines. However, the American College of Cardiology and the American Heart Association now will define hypertension with a systolic blood pressure of 130 or higher and a diastolic blood pressure of 80 or higher. This change has increased the prevalence of hypertension in the United States from 32% to 46%. The ACC and AHA classification now includes the stages of elevated, stage 1 and stage 2 hypertension categories, and this emphasizes the increased cardiovascular risk associated with even slightly elevated blood pressure. This is a chart that is in your book, table 27.1. This just looks at the guidelines for the ACC and AHA and the JNC 7 and 8 and their guidelines and classifications of prehypertension or elevated versus their stage 1, stage 2 blood pressure diagnoses of hypertension. And this is just a map of hypertension prevalence in the United States. As you can see, the southern states, Tennessee, Georgia, Louisiana, all have higher prevalence of hypertension in adults greater than age 20 and older. So hypertension does increase with age, the prevalence, and it varies by ethnicity and gender. It is highest among African Americans, which often develop it at younger ages than Caucasians. Additionally, hypertension control rates are better in women, older adults, and those with higher socioeconomic status. Despite many medical advancements, 35.3% of adults with hypertension are unaware of their condition, and 45.4% do not have it under control. Among adults 75 years of age and older, 80% of men and 85.6% of women have hypertension. Hypertension is classified as primary, or also known as essential hypertension, or secondary hypertension. Primary hypertension has no identifiable cause and accounts for 90 to 95% of the cases of hypertension. Secondary hypertension results from some type of underlying condition and affects 5 to 10% of adults that is diagnosed with hypertension. Screening for secondary hypertension is recommended for any new onset or poorly controlled cases of hypertension, treatment-resistant hypertension, abrupt onset hypertension, and in patients under 30 years of age. It may also be suspected when hypertension is accompanied by severe organ damage such as stroke, retinopathy, heart disease, chronic kidney disease, or peripheral artery disease. So we're going to deep dive into the pathophysiologic processes of blood pressure and hypertension. So again, blood pressure equals the cardiac output times peripheral resistance. So we can see result from increases in cardiac output, peripheral resistance, or both. Increases in cardiac output often are related to an expansion in vascular volume. Again, there's no precise cause for hypertension that can be identified, but oftentimes it's multifactorial. So we'll see a dysfunction in the autonomic nervous system, increased renin-angiotensin-aldosterone system, resistance to insulin action, and activation of the immune system. So some key pathophysiologic mechanisms of hypertension. So overactive sympathetic nervous system. So the sympathetic nervous system normally adjusts blood pressure by controlling heart rate and vessel constriction. In hypertension, the sympathetic nervous system is overactive. This is going to lead to increased heart rate and contractibility. So that will lead to higher cardiac output. We'll see vasoconstriction, which is going to increase our peripheral resistance, and then higher renin release. So we're going to have more angiotensin II, which also will worsen hypertension. When we have a dysfunction of the renin-angiotensin-aldosterone system, the RAS regulates blood pressure by adjusting blood volume and vessel tone. In hypertension, excess renin from the kidneys will lead to more angiotensin II, which is a potent vasoconstrictor, and it will increase our blood pressure. Will also lead to more aldosterone, which is going to cause us to retain more sodium in water, which is going to expand our blood volume and thus increase blood pressure. When we have endothelial dysfunction, the endothelium, which is our vessel lining, will release factors to relax or constrict vessels. In hypertension, there is less nitric oxide, which is going to reduce our vasodilation. So more endothelin-1 will cause increased vasoconstriction. Chronic inflammation damages to vessel walls will also promote stiff and narrowed arteries. In kidney dysfunction and fluid retention, so our kidneys will help control blood pressure by excreting excess sodium in water. When that is impaired in hypertension, we're going to see sodium and water retention, which will lead to increased blood volume and overall increased blood pressure. We'll see activation of the renin-angiotensin-aldosterone system, which also will worsen vasoconstriction and fluid overload. When we look at hormonal and metabolic factors in hypertension, we see insulin resistance. So that's seen in obesity and diabetes, which is going to increase our SNS and renin-angiotensin activity. High cortisol levels is going to enhance the SNS and also raise our blood pressure. This is just a picture of the neural control of blood pressure. So essentially it's kind of breaking down in picture form the last slides that we just talked about. Again, this is our renin-angiotensin-aldosterone system, and going through the steps of how our kidneys and our body will sense a drop in blood pressure, and it will release angiotensin to be converted to angiotensin 1 to angiotensin 2, and then cause us to have a vasoconstriction in our vessels and to retain sodium and water. In normal homeostasis, this works and regulates our blood pressure correctly and keeps it at a level that's going to perfuse our organs. When there's a dysfunction is where we'll see hypertension. Some gerontologic considerations with hypertension. We do have structural and functional changes that happen in our heart, vessels, kidneys, and this will contribute to increases in blood pressure as we age. These changes are going to include artery stiffening, plaque buildup, and kidney dysfunction. With age, we'll see a systolic and diastolic blood pressure increase until age 60. After age 60, we see our diastolic blood pressure decrease with our systolic blood pressure continuing to rise. And this leads to what is called isolated systolic hypertension. Isolated systolic hypertension is the most common form of hypertension in our older adults. And we want to make sure we treat this because it does increase risk of heart disease, stroke, and death. So we want to make sure we keep blood pressures controlled even in our gerontologic population. Chart 27-1 in your book, this looks over risk factors for hypertension. So of course we talked about some of these: advancing age, African American race, chronic kidney disease, diabetes, drinking alcohol and smoking is associated with hypertension. Of course, non-modifiable risk factors are going to be our family history, our gender, and then just poor habits, sedentary lifestyle, and so on. So clinical manifestations of hypertension. When we do a physical exam, we may not see any abnormalities other than an elevated blood pressure. When we start seeing symptoms is usually when there's some type of vascular damage or organ damage. So in the eyes, sometimes we will see retinal damage, and this will include symptoms of hemorrhages. We might see exudates, arteriolar narrowing, and cotton wool spots. And a lot of these, so the hemorrhages you may be able to see. The other things you likely will see if you were to perform, or the physician was to perform, a fundoscopic exam. The heart will see coronary artery disease, and this can lead to angina, where you have chest pain and even myocardial infarction. Left ventricular hypertrophy, so this is where we have enlargement of the left ventricle, and this happens due to increased workload. So if we have a high peripheral resistance, the heart's having to work harder to pump that blood out into the rest of our tissues. So that can increase that cardiac output and workload and can actually lead to heart failure. Kidney dysfunction, we can see an increased BUN and creatinine. We might also see nocturia, where they have frequent nighttime urinations. And then with our brain, of course, we'll see some type of cerebrovascular involvement. This can be anything from a TIA or a stroke, and symptoms specific to that. So that'll be vision, speech changes, dizziness, weakness, falling, hemiplegia, hemiparesis. To diagnose hypertension, we want to make sure we're getting an accurate blood pressure measurement. And to be diagnosed with hypertension, it requires 2 or more readings on 2 separate occasions, with the exception of a blood pressure of 160 over 100 or greater. And that's confirmed twice in one visit. So if you get a very high blood pressure, 160 over 100 or higher, you want to make sure you let the patient sit there for a minute and recheck it to confirm that it is actually that high. Keep in mind that clinical blood pressure readings may not always be accurate. Home blood pressure measurement is considered a more accurate reflection of blood pressure status, just because some people can be nervous when they're at a doctor's appointment or getting their blood pressure taken. So we want to make sure that we're getting accurate readings. One way to do this is home and ambulatory blood pressure monitoring. So this is very reliable and often more reliable than in-clinic readings if patient is doing it correctly. So this is going to help us confirm our diagnosis of hypertension, but it's also going to help track our treatment that we have our patients on. So if a patient is trying to initiate lifestyle changes or medications, oftentimes provider will ask that the patient take their blood pressure at least twice a day to kind of monitor to see how that blood pressure is trending and responding to treatment. Some special blood pressure patterns that you need to be aware of is masked hypertension, and this is less common, but is where we can see a normal in-clinic blood pressure, and then we see high blood pressures at home. This is can cause an increased risk for cardiovascular events, and that's because oftentimes if they have high blood pressures at home and they're normal in clinic, well, we're not catching those pressures. Oftentimes a person is not going to be checking their blood pressure at home unless they're instructed to. They're not going to be instructed to if it's always normal in clinic, so they're not getting that high blood pressure treated. White coat hypertension, so that's where we see that high in-clinic blood pressure that is actually normal at home. So again, this is why we want to make sure we are getting accurate readings, having the patient take blood pressures at home so we can make sure we're not inaccurately diagnosing a patient with hypertension and starting them on treatment. Measuring blood pressure and doing it accurately is very important. So if you remember in fundamentals, talked about different sizes of blood pressure cuffs and how to accurately measure blood pressure. So we want to make sure the cuff is the right size. If it's too small or too big, we're going to get an inaccurate blood pressure. We want the patient to sit quietly with their arm at level of the heart. And again, confirmation of diagnosis by an average of 2 blood pressure readings. You want patient to have an empty bladder and sit quietly for 5 minutes prior to taking their blood pressure. Also avoid eating, smoking, drinking caffeine, or physical activity prior to blood pressure being measured, as these all can increase the blood pressure reading. History and physical assessment of hypertension. So we want to get a good history from our patients, and we want to know when their onset of hypertension started and any health history that can be used to determine if the patient has primary hypertension versus secondary. We also want to know if there's any family history of hypertension, as genetics can be a strong indicator of risk of hypertension. Physical exam findings, again, usually we won't see exam findings unless we have some target organ damage or if we have secondary hypertension. So assessment findings that we may see with our peripheral pulses, we can have weak or absent pulses, and this can be indicative of vascular disease. When we are examining the neck, we may see or hear carotid bruits, may see distended veins, enlarged thyroid. Examination of the heart may reveal signs of left ventricular hypertrophy, and that we will see with the displacement of the apex of the heart. We'll see sustained and enlarged apical impulse and presence of an S4. Eye exam, again, we can see hypertensive retinopathy, so hemorrhages, cotton wool spots, and papilledema. And sometimes we can even hear a renal artery bruit with the kidneys. Laboratory and diagnostics. So common tests, we're going to do a urinalysis, and that's going to help us evaluate kidney function and possible kidney damage. With the urinalysis, if we see protein in the urine, that often can tell us that there's some type of insult to the kidneys. Blood chemistry, we want to see the patient's sodium levels, potassium levels, creatinine, glucose, and cholesterol. With sodium and potassium specifically, we want to make sure we have a baseline for those before those patients, if they do have hypertension, are started on any medications. Electrocardiogram or ECG, EKG, that can actually detect left ventricular hypertrophy. Echocardiogram will further assess heart structure. And additional tests, if we need them, would be renin levels, other certain urine tests, creatinine clearance. All those will evaluate kidney function. Medical management for these patients. So our goal is to prevent complications and maintain a blood pressure of less than 130/80. We also want to educate our patients on lifestyle modifications. So if they're overweight, we want to instruct them to work on weight reduction, DASH diet, so low sodium, high potassium diet, high potassium if they do not have any type of renal or kidney dysfunction. And this can actually lower the systolic blood pressure by 11 to 16 millimeters per mercury. Regular physical activity, reduced alcohol consumption, quitting smoking if they smoke, pharmacologic therapy. So this is going to be prescribed to decrease peripheral resistance and blood volume and decrease strength and rate of myocardial contraction. So depending on what type of medication is prescribed is what the action of the drug is going to do. Additional management, patients suspected to have secondary hypertension must be accurately screened and disorder identified and treated in order to bring blood pressure to normal levels. The recommended treatment for patients with elevated blood pressure but who are not diagnosed with hypertension is lifestyle changes with follow-ups in 3 to 6 months. Chart 27-2 shows different lifestyle modifications and their effect on lowering blood pressure. So pharmacologic therapy for hypertension. So this is prescribed to lower blood pressure and reduces risk of cardiovascular disorders, cerebral vascular disease, and death. Our first-line therapy often is thiazide or thiazide-like diuretics, ACE inhibitors, ARBs, and calcium channel blockers. For African American patients with hypertension and without heart failure or chronic kidney disease, should be prescribed either a thiazide diuretic or calcium channel blocker as a first-line agent. And that's typically because they'll respond better to those two types of medications or classes of medications over the ACE inhibitors or ARBs. Resistant hypertension is where we have 3 blood pressure medications from 3 different classes and blood pressure is still not at target. And risk factors for this type of hypertension is obesity, African American race, chronic kidney disease, and diabetes. So again, classes of medications that you may see prescribed for patients with hypertension are going to include diuretics, beta blockers, or alpha-1 blockers, or combined alpha and beta blockers, vasodilators, ACE inhibitors, ARBs, calcium channel blockers, and this can be in the dihydropyridines or non-dihydropyridine class, and then direct renin inhibitors. There is a chart in your book, 27-4, that breaks down the actions of each one of these medications and when they would be prescribed. This is a chart in your book as well. It's just oral antihypertensive medications for patients with select comorbid diseases. You don't have to memorize this. I just thought it was a pretty good little chart to understand why certain medications may be prescribed for one patient and not the other. And this is from your farm book. It just shows the site of action of different classes of medications and how they work on the body. So some collaborative problems and potential complications of hypertension, again, will include left ventricular hypertrophy, myocardial infarction, heart failure, transient ischemic attack, cerebral vascular disease, so that can be CVA, stroke, or what people will call a brain attack, renal insufficiency and chronic kidney disease, and retinal hemorrhage. Planning and goals for our patients with hypertension. We want our patients to understand the disease process and its treatment. If they understand the risks associated with untreated hypertension and what they need to do to treat it, they're going to be more adherent to the prescribed treatment plan. And then participation in a self-care program. So any type of program that's going to help either get them to target weight, help them with their diet, anything that they can do to help participate in their self-care, they're going to have better outcomes. We also want to have absence of complications, and this is going to go into adherence to the treatment plan. And then lowering and controlling blood pressure without adverse effects or undue cost. So with any type of medication, we know there can be adverse effects. So trying to keep patients' blood pressure under control with the least invasive management possible. And then also understanding that some of these patients cannot afford expensive medications. So as a nurse, when you're discharging patients from the hospital, if they're coming in with a new diagnosis of hypertension, be sure that you're evaluating if they can actually afford the medications. Familiarizing yourself with places patients can get medication on the $4 list or $5 list is very important for patients to be able to adhere to their medications. A lot of elderly people are on a fixed income. A lot of people in general are on a fixed income, and being able to help point them in the right direction so they can be adherent to their medication and prescriptions is going to be extremely helpful. Other nursing interventions, of course, increase their knowledge, so support and educate the patient about their treatment, promote adherence to their therapeutic regimen, promote home and community-based and transitional care. So follow-up, especially having them follow up with their PCP if they've been in the hospital, and especially if they are started on a new medication. Specific medications, a lot of them will need, follow up with their primary care so they can recheck that blood pressure, recheck certain lab work after being on the medication for so long. And then making sure they know to monitor their blood pressure daily and the signs and symptoms of any complications associated with hypertension. Some gerontologic considerations with treatment of hypertension. So with our elderly, remember, it can be difficult for them to remember their medications. I already said expense can be a challenge, so trying to keep it to the least amount of medications as possible. So monotherapy, if we can do that, is going to be the best for them. It'll increase their adherence as well as decrease their cost. Make sure they can adhere to the regimen, that they can read the instructions, that they can open their medication containers, and that they have the ability to get their prescriptions refilled. If they have a caregiver or family member, include them when you're given this type of education so they can help the patient stick to their medication regimen. Now we're going to move on to hypertensive crisis. So this is an emergent situation that occurs when we see a systolic blood pressure of greater than 180 or a diastolic blood pressure of greater than 120. There are two types of hypertensive crisis that patients can experience. The first one is hypertensive emergency, and this one requires immediate treatment to prevent permanent organ damage. And then there is hypertensive urgency, where there is no immediate organ damage evident, but it does require prompt intervention so it doesn't progress to a hypertensive emergency. This can happen with an unknown cause or with secondary hypertension, but oftentimes it's due to poorly controlled or undiagnosed hypertension, or very often abrupt medication discontinuation. So say a patient wasn't able to afford their medications anymore, they just stopped taking them, they can have what's called rebound hypertension, and it can rebound to these levels that are extremely elevated and emergent to be taken care of. So hypertensive emergency, so this is where we see a severe blood pressure elevation with that systolic being greater than 180 or diastolic greater than 120 with new or worsening target organ damage. So this is going to include hypertensive encephalopathy, ischemic stroke, myocardial infarction, heart failure with pulmonary edema. Pulmonary edema is where we have fluid on our lungs. Aortic dissection, so where we have our actual aorta kind of splitting apart. And then renal failure. Management of these patients is going to include ICU admission because these patients are going to be very hypertensive. They're going to need continuous blood pressure monitoring and close care. These are treated with immediate IV antihypertensive therapy. Nursing care, you want to provide a rapid focused assessment to identify possible causes and any target organ involvement. Monitor blood pressure frequently, anywhere from 5 to 30 minutes. Then you're going to titrate the IV antihypertensive drugs to get the desired blood pressure. And with these patients, there is a amount of time that you want to lower the blood pressure. So with general hypertensive emergency, you want to reduce the systolic blood pressure by no more than 25% in the first hour. If stable, 160 over 100 millimeters per mercury in 2 to 6 hours. And then gradual blood pressure normalization within 24 to 48 hours. And the reason we do this slowly is if we lower it too quickly, we can have some cerebral and perfusion issues. So we want to make sure we don't drop it too quickly. Our first line IV medications that's often given is going to be nicardipine, clevidipine, labetalol, esmolol, nitroglycerin or nitroprusside. And with consideration of those medications, there's not a clear superior drug out of these that I've just listed. It's just going to depend on the patient's condition and the urgency and what's going to work best for them. With hypertensive urgency, this is a severe blood pressure elevation of a systolic greater than 180 and a diastolic greater than 120 with no evident target organ damage. And this is going to be confirmed through our exam and labs. Patients are stable, but they do require urgent blood pressure control. You want to prevent them from ending up with target organ damage and progressing to a hypertensive emergency. Common cause of this is going to be non-adherence to medication, again, rebound hypertension due to missed doses. And management often is going to include restarting or adjusting their antihypertensive therapy. We want to address any underlying causes to prevent the reoccurrence of this and use a team-based approach and educate our patients on preventing future hypertensive urgency episodes. Pharmacological management and nursing care. So oral agents can be administered with the goal of normalizing the blood pressure within 24 to 48 hours. We can administer fast-acting agents, even if it's not something the patient normally takes. We can do a beta-adrenergic blocker like labetalol. We can do an angiotensin-converting enzyme inhibitor like captopril, or we can do something like clonidine. And clonidine you'll see out in practice a lot of times for very high blood pressures that are not in that hypertensive emergency state. They're just in that hypertensive urgency. These patients also require close monitoring of blood pressure and cardiovascular status. And you want to keep assessing them for potential evidence of target organ damage.